नमस्कार दोस्तों, गुड इवनिंग, वंस अगेन वेलकम टू फर्टिलिटी दोस्त। चलिए बात करते हैं रीजंस फॉर इम्प्लांटेशन फेलियर। आपने सोचा विदाउट गिविंग एनी इंट्रोडक्शन अबाउट द डॉक्टर, हमने सीधा टॉपिक पे आए बिकॉज दिस इज रियली वन ऑफ द वेरी इंपॉर्टेंट टॉपिक फॉर मी। यू कैन से दैट क्लोज टू हार्ट बिकॉज इतने सवाल आते हैं इससे और लोगों को लगता है कि ये मेरे साथ क्यों हुआ, इम्प्लांटेशन फेलियर क्यों हुआ, मेरे एग अच्छे थे, एम्ब्रियो अच्छे थे, स्पर्म क्वालिटी अच्छी थी, ट्रिपल लेयर था, मेरी एज परफेक्ट थी, यूट्रस में ब्लड फ्लो भी बहुत अच्छा था, थायराइड, डायबिटीज ऐसा कुछ भी मुझे नहीं था, वेट गेन भी नहीं था। देन ऑल्सो अगेन व्हेन आई वेंट फॉर ट्रांसफर एंड फेलियर, क्यों ऐसा? सो हमने सोचा बात करते हैं इन सब टॉपिक्स के बारे में बिकॉज दिस इज रियली वन ऑफ द वेरी इंपॉर्टेंट फैक्टर व्हेन यू आर गोइंग फॉर आईवीएफ बिकॉज अगेन द होल process of IVF, we divide the process into two part. So first जो है retrieval part OPU वो हम कर लेते हैं आराम से, टेंशन भरा एंजाइटी भरा जो पार्ट है वो हमारा सेकंड पार्ट रहता है। एंड आफ्टर दोज 15 days ऑफ वेट जब पता चलता है कि आपके लेवल्स लेस देन 2 हैं या बहुत, अगर 2 से ऊपर भी हैं तो बहुत कम है या है ही नहीं, सो वो सब कुछ पूरा प्रोसेस फ्रॉम द बिगनिंग टिल एंड हमें बेकार लगता है और हम फिर सोचने लगते हैं कि क्या रीजन थे। और कई बार वो रीजन मिल जाते हैं, बहुत बार वो रीजन रह जाते हैं एंड वी जस्ट स्टार्ट स्क्रोलिंग गूगल कि अच्छा वेट इतना था और कम कर लूं, ओहो थायराइड इधर पहुंच गया, लेट मी वर्क ऑन दिस। बट एक्चुअली है क्या? क्या आपकी बॉडी में कुछ और हिडन फैक्टर्स या पैरामीटर्स ऐसे तो नहीं है जो कहीं पकड़ में नहीं आ रहे, और कुछ ऐसे इंपॉर्टेंट डायग्नोसिस हैं जो आपके डॉक्टर कहीं ना कहीं मिस कर रहे हैं? सो वी आर गोइंग टू डिस्कस दिस एंड जब हम बात करते हैं इसकी, हमें यूएनएस ने एक बहुत बढ़िया डॉक्टर से मिलवाया, डॉक्टर इमराना। आपने उनके साथ हमारे 2 to 3 लाइव्स देख लिए हैं एंड सो वी कैन से दैट ऑन पब्लिक डिमांड वी आर हैविंग डॉक्टर इमराना अगेन विद अस। एंड थैंक यू, स्पेशल थैंक्स टू यूएनएस फॉर अरेंजिंग दिस सेशन बिकॉज डॉक्टर इमराना बहुत बिजी रहते हैं, टाइम निकाल के आते हैं। सो व्यूअर्स आप प्लीज अपने सवाल पूछने शुरू कीजिए, मैं उनको इन्वाइट कर रही हूँ एंड लेट्स स्टार्ट विद द सेशन। नमस्कार डॉक्टर इमराना, वेलकम टू फर्टिलिटी दोस्त।
Namaskar. Thank you for the honor and thank you for the love which you people have conferred, that I'm really connected to all of you, and um, like we
Thank
can just go.
Yes. So, viewers, Dr. Imrana is from Jan IVF Center, Tarapur, Bhagalpur. She is a clinical director. She is fertility specialist and endoscopic surgeon also. बहुत लोग पूछते हैं कि लेप्रोस्कोपी करवा ली, हिस्ट्रोस्कोपी करवा ली, अब क्या? तो अगर वो भी सवाल आपके दिमाग में है तो आप प्लीज जरूर पूछिएगा। और सबसे इंटरेस्टिंग चीज जो मुझे यहाँ लगी कि इन द पास्ट 6 years शी हैज गिवन स्माइल टू 600 कपल्स। ये बहुत जरूरी, बहुत इंपॉर्टेंट है, बीइंग सीन द आईवीएफ सक्सेस रेट्स एंड ऑल दैट। सो कहीं ना कहीं कुछ ऐसे हिडन फैक्टर्स हैं जो डॉक्टर इमराना जरूर सॉल्व कर सकते हैं। सो डॉक्टर, लेट्स स्टार्ट विद आवर मेन टॉपिक, रीजन फॉर इम्प्लांटेशन फेलियर। और हमारे पास बहुत सारे सवाल हैं। सबसे पहले हम बात करें तो एक सीड की, एम्ब्रियो की बात करते हैं। सो व्हाट आर द फैक्टर्स, और यहाँ यूं कहिए कि हमें क्या देखना चाहिए जब हम एम्ब्रियो ट्रांसफर के लिए जा रहे हैं? एम्ब्रियो कैसा है, डे 3, डे 5, कुछ भी रिलेटेड टू एम्ब्रियोज जो आपको लगता है कि एम्ब्रियो की ये वाली हेल्थ हमारे इम्प्लांटेशन को इम्पेक्ट कर सकती है।
Yeah, that's a wonderful question from somebody who is really wonderful, like my horse. I love you there, Purnima. Um,
Thank you.
yeah, and all the team members. I congratulate them for conducting it so very smoothly and nicely. I just want, there are a lot of interesting aspect to this implantation failure, or a lot of things where we really want to have a realistic opinion about this thing. Implantation, we have to be realistic opinion regarding this implantation failure, because there are certain things which is exactly not in our control at all, in the control of the clinician, in the control of the medical science, and still we are into research, and still into we are into research, that despite for all those desperate and disappointed couples, for all those where we can do our best, where we have made a wonderful embryo, which is a we can say we generally, since you talk of the best seed and the soil we'll consider later, the seed is the embryo. How we make the embryos, we have used our best capacity in making embryos, like it is implantation. If it fails in a day 5, that means at a expanded blastocyst stage. And even some centers where they do a pgta, that is you biopsy some cells out of that blastocyst, and you even can judge those embryo, where embryo this thing what we are considering in generally is the morphokinetic parameters, that is morphologically by look, how beautiful the embryo looks, and it satisfies the standard protocols which is valid for the entire globally, and which we follow, that number of cells, this has to be, there is no granulation, there is no like ecogenic things, or which satisfies the criteria for a good blastocyst under the microscope, for an embryo to be a perfect and a nice blastocyst. And then by that we mean that it has crossed level of maturity which we are expecting it, because the crucial journey for an embryo, for a seed, is from when it is growing from day 3 to day 5, and day 5 is the day when the blastocyst is formed. So despite that, and when we do a biopsy, a trophoectodermal, certain centers they offer PGT. And when we do that, and that also comes to be claimed to be a normally chromosomally patent and chromosomally competent with the normal number of chromosomes of the embryo, despite that things fail. So what exactly the problem is at the microscopic level. What we are seeing is morphologically, and what embryo, when it goes, there is a cross talk of the embryo and the seed and the soil, and the embryo itself makes its way into that endometrium. There are a lot of immunological factors, lot of genes which are upregulated, and lot of genes which are downregulated. So it is all a microscopic event, and embryo wonderfully keeps on rolling, dancing into the endometrium, and where it finds its way, the best patch and the best land which it gets to stick to the endometrium, there only it will breach the epithelium, luminal epithelium of the endometrium, and it will penetrate there. It will first oppose, then there's adhesion with the help of cathedrines and lot of molecular events that follow, and then there is a penetration, and finally the implantation, which is the most awaited journey. Part of the journey is there. So, what we know till now is up to the chromosomal levels, but we have not studied multiple genes. There are folliculin gene, Fordex genes, there are multiple genes. So, there might be the genetic numbers, the genes which are on the chromosomes, they may go fallacious. And there are a lot of still now we have 30,000 genes which are available, and the genetic mutations, deletions, and a lot of duplications, can be balanced translocations at the level of the genes, which we do not know. And there may be 6,000 number of genes and genetic related problems are incriminated, which is beyond our scope for a normal fertility specialist to consider all those genes, and then go ahead examining each and every. So there might be problems at the level of the genetic. What we are seeing is a morphologic parameter. By the look, we generally pick up the best, and we consider that if embryo reaches the stage of blastocyst, we should be happy. And if we can enhance our rates by 2 to 3%, if we supervise our labs also, the laboratory conditions, culture conditions, when we the freeze thaw process of the embryo, because most of it, and whenever even if it is not there, not implanting, then we should consider the natural cycle implantation also, with the help of a normal corpus luteum and the this thing, normal corpus luteum, which is elaborating estrogen, and the good line is prepared, a good soil is prepared. In even despite that it fails, not every time the hormonal treatments for the endometrium to develop, then we consider that it can be implantation. So it is something which is really microscopic and which is not under control. There are certain things we need to go for certain miles more, an extra mile always is left, and that is why we are not able to catch up with that rate. So we have to be having realistic opinion about it. And I mean, God is there, so we have always to be praying our best. And so it seems that really there is one thing, and at the end of the day, despite the entire workup and everything, putting our best capacity into it, it's just the 30 to 40%. Because if there is a day 3 embryo, cleavage stage embryo, there are 35% of the implantation rate, that is 65% will be left out.
Right.
And if it is day 5, it is 50% of the implantation rate for so this is so far as the seed is concerned. And over and above, we can enhance, I mean, achieving a blastocyst is also there are, as I said, there may be the genetic alterations, and that may be associated, which is yet to unfold, yet to uncover, that we are not looking. We can check up to the level of the chromosomes. We cannot, we are not verifying all those genetic problems. Even mosaic embryos develop, even, but they become later on growth arrested, and some may develop. So if you put one blastocyst and if you put three grade 3 embryos, so all those three might not go, they might get arrested, and one may go to the level of the blastocyst. Blastocyst ideally should be transferred at all the centers, and we should try to culture to this level of the blastocyst, because that shows that because the endometrial receptivity is uterine environment naturally is prepared to accept a blastocyst only. And because it is a 5-day journey in the natural fertilization process, and there the endometrium is primed in a way naturally that it should it is an ideal environment for the blastocyst. Cleavage is something which is pre this thing, it is a pre mature, I mean, it is 2 days behind. It is not ideal for the cleavage stage embryo to ideal conditions in the as offered by the nature to set into the endometrium. So ideally, endometrium is primed to get a blastocyst only.
But doctor, there are
By
many cases, or we can say that with advanced age, only day three embryos are available. So, what you suggest in such cases, like how you suggest them to prepare their uterus for day three transformation? Uh,
yeah, we do dot of day 3 embryos, not necessarily the cleavage stage embryo, that is 8 cell stage, but they also implant. But the reason for the advanced age, because they become growth arrested. They might not be chromosomally competent embryos. That is why they get apoptotic.
Mhm.
That is why. So we can do a lot of STEM. GCSF is available to enhance the soil. There, the soil takes over the hand. If the soil is good, that may compensate for that less competent embryo. So it's ultimately supplementing and complementing things. You can go for a PRP. You can go for a natural distinct cycle,
Exactly,
and
right.
then, the wonderful lining, and then we have put a doctor also, and still you we can. So we do our best, but that's what I said. It's the crosstalk and the microscopic, and that cannot be translated into the real time events.
Doctor, we have one query related to this fresh cycle transfer. So the age of lady is 29. When she started with IVF, before this IVF failure, she had three failed IUIs, and डॉक्टर ने उसका फ्रेश ट्रांसफर किया. So she is just asking the ET was good, it was 9.7 mm. So could the reason for failure could be the fresh transfer?
Yeah, because we never know, because sometimes the fresh transfer we have elevated progesterone level. So was the progesterone done before transferring? I don't know. But, I mean, that is very important, because
Right.
you have to have a progesterone between 1 to 1.5. We consider it our center at 1.2. We do not do, if the elevated progesterone is there before
Mhm.
transferring, we cancel those patients, and we do it because that is very very important. That shows the premature closure of the implantation window, and that means that is not, endometrium is not receptive. It may be receptive prior, or it may be, it was receptive prior maybe. And
Mhm.
yeah, because the pinopods, which are small projections at the level of which makes it more receptive and beautiful, and kind of the pinopod expression of the endometrium, which are the small projection tongue like, and at the molecular events are all not synchronized. That means the endometrial and the cellular and the glandular stromal, endometrial glandular stromal desynchronization is there. So that is, the dysregulation lies there. There is no synchronicity at the stroma and the glands. The gland and the stroma, they are not synchronized. So there
Mhm.
is a premature closure, there is an advanced maturation, premature closure of the secretory changes have started already taking place, because of the, when we find an elevated progesterone, the secretory
Mhm.
changes affected beforehand, so that the window is already closed. You should have a proper window to get the this thing implanted. So I don't know whether this was done or not. So
Right.
that is what happens, this phenomena happens in the fresh transfer. So whenever we do a freeze-all, we always get a progestogen level done.
Okay, I think this could be the reason, and doctor missed this. And again, if you are planning to go for frozen
Then
transfer, you could
what
just ask.
yeah, they can, she can go for a frozen transfer in the
Right,
next.
right.
That can
Right.
be, that will be helpful.
So, doctor, we can say that whenever we are planning fresh transfer, so the progesterone levels are really important, along with that endometrium thickness and vascularity and all that.
Yeah, all three taken together. Progesterone has to be less than 1. It has to have be less than 1, always less than 1, between 0.5 to 1.2.
This is really very important point over here. Viewers, please note because we have many queries related to this fresh cycle transfer failure. So प्रोजेस्ट्रॉन के लेवल्स रीजन हो सकते हैं. आप एक बार जरूर चेक कीजिए. अब तो आपका ट्रांसफर फेल हो गया, बट हम ये चाहेंगे कि नेक्स्ट टाइम whenever you are planning your frozen transfer, then also you can check these parameters. And viewers who are going for, or their doctor has been suggesting them for fresh, then please do check progesterone levels also. And Dr. Imrana, next question is related to adenomyosis. And we have many queries related to this. Doctor detected adenomyosis, but it was not before there. Doctor said that let's wait for 2 to 3 months. What exactly is this adenomyosis? Or if I go for transfer with this situation, is it going to hamper my success?
Yeah, definitely. Because adenomyosis is one dreaded thing which we want to, because there is a disruption at the endomyometrial junctional zone. That is very,
Mhm.
very important. And the junctional zone has to be less than 12 mm. Always, that endomyometrial junctional zone is very, very important in the case of adenomyosis, and depends what kind of adenomyosis. Sometimes it is a diffuse pan global adenomyosis where the uterus is simply enlarged and the endometrial thickening is always good, and we don't have myometrial cyst. Sometimes adenomyotic uteruses, they become very enlarged and bulky, and the uteruses are very heavy, and that might expel the embryo, while it's not the expulsion of the embryo, it's the acceptance. There is immune alteration of the entire environment. So before while how we define, we need to shrink the size of the uterus to make it more receptive for the endometrium, for the embryo. And for making it, we need to go for injection lupodex. We all know GnRH agonist beforehand, and so that we make it to a particular fit into that volume of the normal volume, which is 30 to 40 ml of the uterus. Sometimes adenomyotic uteruses may go to a volume of 300 ml. That is too high. 12 centimeter uterus. It can be 10 centimeter uteruses. We need to bring it down to 8 centimeter, 7 to 8 at least, and with a good lining and with a good vascularity. We know it up to 7 to 9, whatever be the deciding there. But importantly, the endomyometrial junctional zone is important. There is a diffuse pan global adenomyosis and there are globular adenomyosis, where one portion of the uterus is affected, that becomes shadowy, fan shaped shadowing, and that becomes very prominent and heavy and hard like a stone. And inside the myometrium of the uterus, we know the uterus has three layers: endometrium, myometrium, and the serosal layer. So that myometrium, inside that myometrium, that ectopic endometrial glands, they come, and that causes the hypertrophy of the muscular layer surrounding those glands. So the entire uterus becomes stony hard. So that really hampers the receptivity, and that globular is all the more bad. It's all the more bad if it is less than 3 centimeter focal adenomyosis. It's okay. If it is more than 3 centimeters, you need an adenomyomectomy for that, by laparoscopy, or because that injections are also not going to more than 3 centimeters of the focal adenomyosis. If it is less than 3 centimeters, okay, by injections we can take care of. 3 shots of every month we can go for injections of lupodex, and then we try to make it more natural, normal, anatomical, and then the receptivity will improve.
Okay.
Because uh, the entire system has to be work in a way. We know that fetus is an allograft. After all, the paternal genes are there, which is not recognizable by the mother. So there are a whole lot of immune alteration process. The Th2 response has to go high. Look how Almighty has designed ourselves, that to accept that graft. It's a kind of accepting a graft. The whole lot of changes that undergo at the molecular level, at the immune levels, at the histological level, at the morphological levels, every level, it is a lot of upregulation of the genes. And I don't also believe in that era. We don't follow that era. It is very costly, where we check the number of 235 genes, how many are upregulated, and then and how many, because the era also, that it holds validity only for 2 to 3 months, not beyond that. If you're doing an era at October, then if you're planning like this putting the embryo in the month of December, then the same window of implantation will not be valid for that month, because this is era is endometrial receptivity array, which is costly test. We take a biopsy from the endometrium and the study the genes. 235 number, how many will be go hoxa 10, hoxa 11. These are the genes which helps in the endometrial receptivity. So they
Right.
might not, how much they are expressed. So I don't think it is a very good test and very much relevant and important. I don't find, because it's really like just to give a backup, and for the patient to convince, okay, it was bad or it was good, kind of. But I don't find it to be much of significance, and it's very elaborate and very cost incurring also.
आई नो। एक्चुअली मैं नेक्स्ट आपसे यही पूछने वाली थी कि योर व्यूज ऑन दिस ERA, because we have seen that doctors are telling their patients that it will help, and recurrent failures के साथ तो it's very common. And doctor, you just mentioned that it is viable only for 3 months, but मैंने कई लोगों से ये सुना कि ये 1 साल तक या 3 साल तक वाइबल रहता है।
जो बड़े सेंटर्स हैं जो बहुत ज्यादा केसेस करते हैं, उनका तो यही कहना है कि ये ज्यादा वायबल नहीं है इसका रिजल्ट, मतलब लाइक बड़े सेंटर्स जो स्टडी, बिकॉज आई डोंट
हम्म।
say my opinion. I don't
हम्म।
go for that test. Rather, I take that patient up for the repeat transfers, or I put much into making the soil better or the embryo better, or do again like egg retrieval and do the things again all over, and do the
हम्म।
fresh this thing. I offer them this, that rather than spending on that era and all, you do start all together again. If you're, I give me one more chance. And because the centers who are doing multiple number of transfers, we have got a very huge number of people, and
Right.
from the outside also India. Actually, era was designed not for the Indian females, from the females abroad. They have studied much era, and those centers who can afford it better, the patients have to be like, it's sort of economic burden also. So
Hmm.
they say it's 4 months validity, they say. This is
Okay.
what I know.
Right. Because nowadays ERA is very commonly discussed, and people are saying that yes, I went for this, and
Then fail again. After
right,
that
right.
also fails. So sheer luck.
Right. So, doctor, what all we can do? Like, we can, as you just mentioned, we can check the progesterone levels, we can check vascularity part of things. So, what all other tests or other things like PRP is very common when we talk about thin endometrium lining. So, uh, आपके हिसाब से PRP को हम कितना वेलेट मान सकते हैं, और it could be a much help in thin endometrium cases?
In 20% of the cases, it can be helpful. Not every patient will be a suitable candidate for PRP. Then stem
Okay.
cell now it is getting much impetus, and many people are practicing also. It is better than PRP. I mean, always better. Then if we do the PRP into the subendometrial layer, it is only good. Otherwise, just putting a PRP is not all that good, because it will generate all those growth factors and all those things, and scratching and all those that we always
Yeah.
practice. You glue, not everybody advises, but I do. It's hyaluronic acid, which is more concentrated form in the form of embryo glue. It's just that the culture media, it's more, we use that. We do all those things where we can enhance the receptivity. Then the subtle infections, chronic endometritis, polyps, fibroids, Mullerian septum resection. If there are Mullerian anomalies, they can be resected, and that can be whatever best we can do for the soil. We have to be doing anti-tubercular drugs, even if the results are
Right.
negative. Yeah, that also really helps. And whatever can enhance, then sildenafil citrate, sildenafil, not
Right.
much of evidence based. Arginine, not much of, because all they are supposed to go for endothelial dilatation and improve the vascularity. Certain places they help, certain, no evidence based studies are there for all these sildenafil and all those 25 milligram. Arginine also, nitric oxide, relax it. They release nitric oxide and they relax the spiral arterioles and the vascularity at the bed of the endometrium. Then ecosprin and all these are already there. Only they perhaps ecosprin helps. GCSF, everything we can do, whatever masala we can put. I mean, just to enhance the things. And we pray to Almighty that, like, at the end of the day, the prayers work. Probably this is what
Right.
I feel.
बिल्कुल, बिकॉज़ इसमें तो कोई लाइक as a doctor also you cannot give any guarantee or anything like this, right? Doctor, very common question again is related to hydrocelphings. सो अगर ये इन्फेक्शन है तो बहुत लोगों को लगता है डॉक्टर ने बोला ट्यूब क्लिप कर दो एंड इट वाज लाइक ओ गॉड अगर ट्यूब्स क्लिप हो गई तो आई जस्ट लॉस्ट द चांस ऑफ नेचुरल कंसेप्शन आई डोंट वांट टू गो फॉर दिस बट इन मेनी केसेस क्लिपिंग डू हेल्प so I want you to explain this hydrocelphings and if we are dealing with this kind of situation, this infection, then how clipping of tube can help because many people are under this impression एक बार ट्यूब क्लिप हो गया तो बस काम खत्म और जरूरत क्या है इन्फेक्शन है तो दवाई से ट्रीट कर लीजिए.
Clipping is always a must do. You should never let it go. It is a must do. If it is a hydrosalpinx, it's a must do. Because with the bigger hydrosalpinx, if it is transient, small hydrosalpinx, it might not affect. And but it is a big, which is seen on the ultrasound also transvaginally. Hydrosalpinx can be very beautifully seen. And if you put a 3D ultrasound, then it can all the more very nicely delineate it. Then in those conditions it's a must do because the fluid which is collected, it is embryotoxic. It goes and it adversely affects and adversely impact the embryo which is going to implant, and it will spoil the soil also. So it's very important because as such it is acting as a vestigial organ for the female. It is not going to its functionality of the hydrosalping tubes, hydrosalpinges, is it's not going to function anyway. It's not functioning. Your tubes are all just ballooned up and with a pent up collection of the fluid, and it's not functioning anyway. Not doing any. It has become vestigial. It is all a waste. So it's better to clip so that the fluid which is collected is not traveling and going through the ostia into the soil and spoiling it. So it is a must do. You have to get it clipped
So
before
if you
embarking on the journey of this IVF.
right. So there's we can say that no bad impact on your health if you go for this clipping. Rather, it will enhance the chances of implantation.
Yeah, yeah, 100%.
Right. So, doctor, one another question is related to hysteroscopy because many people are like, उसको hysteroscopy किया था डॉक्टर ने उसका सक्सेस हो गया मुझे नहीं किया मेरा रह गया सो एंड डॉक्टर्स यूजुअली सेज दैट यस यू डोंट नीड इट देन प्लीज डोंट गो फॉर इट बट वी प्रेफर दैट जो भी सबके साथ हो रहा है वो मेरे साथ हो जाए सो व्हाट एग्जैक्टली इज योर टेक ऑन दिस हिस्ट्रोस्कोपी बिकॉज इट इज वेरी कॉमन बिफोर ट्रांसफर डॉक्टर इज सजेस्टिंग हिस्ट्रोस्कोपी और अगर नहीं सजेस्ट किया तो डॉक्टर ने कुछ तो मिस कर दिया आज सो योर टेक ऑन दिस.
Yeah, hysteroscopy is something we can always do. Means if it is a very normal, beautiful uterus and you're not finding anything on the ultrasound, if you find that there may be, there can be certain problems, we find some adhesive bands or something like on the endometrium, which is not properly delineated clearly, proper three lines, beautiful lines, that is not all that wonderful. In that particular case we can go for a hysteroscopy, and hysteroscopy is helps because it automatically is scratching bit of we do, and that with the help of that, what is the purpose of scratching is just release of all those growth factors which are present, and that will help that is if some immune trigger is there, and so that that will which is very important for the making the endometrium receptive, and we rule out at the same time any micropolyp, any adhesion if it is bands or something like there, or sometimes we need some kind of cavity enhancement procedures can be there if the uteruses are small. We make a lateral cuts, and we can at the fundal region also if there's a we can make small scissors, we make little cuts so that that cavity enhancement can be there. And if we can pick up any infection if it is there, that can be clearly seen by the micropolyp, etc., congestion, whether the endometrium was really pale or atrophic kind of, so that what next, what best we can be equipped with before transferring an embryo, and how best we can be so that we can be it can be a guide to our preparedness. how better we can be equipped and prepared for the embryo transfer, and for little subtle things can be just removed, which can be deterrent to or a failure to the implantation, that will hinder the implantation. It can just make it away.
And doctor, what is the validity time period of this hysteroscopy? And if I am going for hysteroscopy right now, and for one or the other reason my transfer got postponed, then do I need to repeat it? Because this is very common question. Because साल में 2 बार किया या 3 बार किया, so
If we are going within further 6 months, we don't need a repeat hysteroscopy at all, because yeah, we don't need a repeat hysteroscopy. We can plan a embryo transfer after 2 months, 3 months, 4 months. I mean, not needed. Not everything I mean, jumps back so very early and quickly, because once you have done and you have seen that everything, I don't think there is a need to do it again.
okay. Once done, it will definitely help your implantation, and again your doctor will check and recommend
But
you.
non-invasive things are there. Ultrasound is there. For
Right.
max, if you want to be really sure, that you can do a diagnostic one. Simple diagnostic sheet is very 2.5 mm, and just put it there without anesthesia, and just put it,
Mhm.
and you see everything without anesthesia. 2.5 mm sheet, and you can just see while the time of scratching. I do scratching on all my patients. It's routine in my practice. So
Okay.
you can do a hysteroscopic scratching, or you do a simple scratching. It's all there. Why? Just take a view of the endometrium.
And doctor, many people just ask that is DNC could be the reason for thin endometrium lining, because we have seen cases where 2 or 3 abortions are there and DNC has been performed, and after those, when they start planning for conception or pregnancy, then doctor says that your endometrium is not perfect, it is not growing. So DNC could be the reason for this thin
Had
endometrium.
been suffering abortion, and somebody had like removed some bits of the basal endometrium, which is the active endometrium layer. Stratum uh, basilis, and then compactum and spongiosum, all these three layers of the endometrium. So there, that is the one functional layer of the endometrium which elaborates all everything. If we remove the basal endometrium, then it might not the endometrium may not be that vascular, it may not grow, it may not elaborate. I mean, the hormones will not be effective over there. So it's very important. Without the basal endometrium, nothing is possible. There might be adhesions, there might be lot of, I mean, the functionalists and the basalists, the two layers which are very important. So the basal endometrium has to be preserved nicely. So you should not over curettage also. The simple curettage, and you take the things away. And multiple times, if she had suffered, might be some impact on the those layers.
Then how to improve this lining? Because
Am I audible?
yes, ma'am. Can you hear me?
Was I audible to all of you?
Yes, doctor. Yes, we could hear
Yeah, I
you.
can hear you.
Yeah, yeah, yeah. Right. It's perfect. Your voice is perfect. So, doctor, if we have this repeated failures and implantation failures, and doctor suggests that lining is again not growing, the things are not. So, what you suggest that we can do to just work on this endometrium part? Because 90% of the cases or 90% of the queries are related to this only, that my endometrium lining is really thin.
Yeah, if it even if it is 6 millimeter and the vascular triple zone, I mean reaching till the third zone layer, then we can go for at the 6 mm also. We can go for a, or then hysteroscopic PRP can be done, then GCSF at the same time, and then all those adjuvants can be given, which we discussed. And if it is not there in the natural cycle, we can try the hormone thing can be taken. We can try different hormones if not possible with the one type of oral tablets. I have also described it in the previous videos, that You can take the form vaginal route as well. We can go for the spray form also if it is not really good, and we can enhance the dose of the hormones. All the estrogen tablets can be, but gradually, not all of a sudden. So all these things can be done to enhance the layer. And even if despite that, for a very like elderly females who have already suffered some problems and everything has shrunken, sometimes it becomes really difficult to grow the endometrium. Then
Right.
surgery is an answer for that.
So, if you are planning your transfer and there are issues related to your endometrium thickness or some concerns related to your embryo, then do talk about it, discuss with your doctor. And again, I would suggest that do watch this live again and again. हो सकता है कुछ चीजें आपको इसमें से ऐसी समझ आ जाएं जो आपको लगे कि आपके डॉक्टर ने आपके साथ डिस्कस नहीं की. Then you can just ask your doctor, एक डिस्कशन कीजिए, हेल्दी डिस्कशन कीजिए, बात कीजिए कि ये ऐसा क्यों हुआ, एंड अगेन इट विल हेल्प इन योर इम्प्लांटेशन. इम्प्लांटेशन फेलियर इज नॉट द एंड. वी हैव मेनी थिंग्स, बहुत सिचुएशंस हैं, बहुत प्रोसीजर्स हैं, टेक्नोलॉजी, मेडिकल थिंग्स इतनी डेवलप हो चुकी हैं कि हम वी कैन हेल्प यू, डॉक्टर्स कैन हेल्प यू इन योर ट्रीटमेंट. सो डोंट वरी, जस्ट लेट अस नो कि आपको हमारे सेशंस कैसे लगे, पसंद आए कि नहीं आए, और अगर आप चाहते हो कि और कुछ टॉपिक्स और कुछ बातें हम करें, देन ऑल्सो प्लीज डू लेट अस नो. आई थिंक डॉक्टर इमराना का आई जस्ट ऐड है
Hmm.
has कुछ so we were just summarizing the session. एंड इफ एनी कंसर्न्स, अगर आपको लगता है हमने आपके कुछ सवाल छोड़ दिए एंड यू वांट टू कंसल्ट डॉक्टर इमराना, देन यू आर मोस्ट वेलकम टू विजिट हर सेंटर. आप बात कीजिए. हमारे बहुत सारे प्रीमियम मेंबर्स के लिए डॉक्टर इमराना ने कंसल्टेशन दिया है, एंड आई बिलीव दैट प्लीज don't hesitate to take the second consultation. The possibility is that कुछ hidden factors जरूर बाहर निकल कर आएंगे. And all the best from our side to all of you. Thank you, Dr. Imrana. Thank you so much for joining today. और implantation failure के reason हमें पता चले, हमें पता चला कि हम कैसे उनको ठीक कर सकते हैं. और अगर कुछ रह गया तो we are always, you are always there to help us out. Thank you.
Thank you so much, and really sorry for the technical glitches which I
No,
had,
no,
and
no, no.
I like I was
नहीं,
busy.
it's perfectly fine. It's perfectly fine. आपने इतना time निकाला and we are really grateful to that. Thank you, ma'am. Thank you for joining.
I really enjoy your fertility toast.
Thank you. Thank you.